Okay. So my topic is how to do it, how to start such a program. And let me see. So this is a short agenda. I only have 10 minutes with the hope of additional 5 minutes since Professor Kofidis is operating. So we would like to see the preoperative operation, operative techniques, and what we have concluded from that. And there has been a shift in the perception of the surgeon from the full sternotomy. As you can see, we make J's, we make small incisions, but here is where we are in our clinic, at least, especially for the mitral, not so very much for the aortic valve, but we do have the smallest possible incision for the minimal invasive mitral valve. So in the preoperative preparation, the first two subjects are you have to know your field, you have to know what you want to do with this aortic valve or mitral valve. And for us, one of the first main pillars are visiting experienced colleagues. And I will lead you through all the rest of it. I did not need to visit colleagues at the beginning because I did have Dr. Perrier in our institution, who's an expert in mitral valve reconstruction. So our intention to implement minimally invasive led me to Leipzig, to Professor Mohr, who introduced minimal invasiveness in Germany for the mitral valve. So I stayed there for 2 months to learn this. And the two guys over here, it's Professor Doll, one moment, I have to go back. Professor Doll and Dr. Kunze are now chiefs of their own departments, were residents at that time and making all sorts of mistakes as they were beginning to do minimal invasive mitral valve. So I learned a lot from them. And of course, Dr. Vanneman, who did truly endoscopic surgery, I think so many years before we even started this, and he was very much propagating it, but we didn't believe that at that time, that we could get there too. So coming back from Leipzig, we needed to create a local team. And one of the important figures is the chief. The chief has to support this the technique or implementing it and support the whole team, or it doesn't work. Of course, you need the anesthesiologist to help you during the operation. They do echocardiography in the operation theater in our clinic. The perfusionists, of course, who play a great role in the success of minimally invasive surgery. And of course, the surgical team, as you see with Dr. Perrier and the rest of us. And also intensive care unit, where we had close, lots of discussions with the intensive care, how to go about these patients. So once we had our local team, we went ahead and did the simulator trainings. You see, these are archaic simulators compared to the ones that you have today. But it helped us to narrow our operative field and do operations in a small, with a very small incision. The next was the quality protocoling. At the beginning, we didn't know, how many problems we will have, and we listed everything what we thought might cause a problem. This is in German, but it's like a cannulation. Did we have problems with that? Did we have revisions of mitral valve? Did we have SAM? Everything was documented. And we usually go for dinner and talk about the things that went wrong or right that day or the whole week, and debrief the patient so that we realize where is the problem? What can we do to be better? And you will see that the first evaluation at the end of the presentation, this was the base for the evaluation. It was very simple, but it did the job. So our clinical protocol did have a lot of exclusion criteria at the beginning. We wanted to start with mitral valve replacement, but as you know, in Europe, replacement is for rheumatic valves, and they have a heavy load of calcification, and we were afraid to do that in minimal invasive. So our first approach was P2, simple P2 prolapses. But we took care that it was not too difficult, not too much concomitant diseases or body weight over 100 kilo. We excluded ejection fraction, age. We were very meticulous to select the patients so that the program, once you start it, you do not want it to fail. You want to have success at the beginning, or the whole team is against you. So we started with P2, as you see here, with a restricted prolapsing area here. and hopefully not too much work at the beginning. And in the OR, we start with the positioning of the patient, the thoracotomy. We have to get to an access to this region. So positioning of the patient is major. And our first incisions were big, really big. So we were not on cosmetics at the beginning, of course. And you could put in your whole hand at the beginning. But progressively, you see, we limited the access, but still using rib retractors and still operating with direct vision. But this is our setup at the moment. The working port is just a working port. All the other accessories are outside of this region. The thoracotomy, we have developed we've tried a couple of accesses. It's this one or the submammillary, a sagittal one, periauricular, alveolar. And here are the clinical pictures. Patients are happy with either of those. It really does not matter that much. And these are the different ones. The one we're using most are this one, the sagittal, and this one for men, mostly for men. The perimammillary is very, very popular. So the surgeon is not looking down in the thorax and nobody else can see anything, but he's sitting upright, looking on a monitor. This is a 2D, in the 2D era. And then we transition to 3D era. Everybody has to wear these glasses so he can see the images, but we have perfect images with the 3D, as we will see maybe later on from the operation theater. So I brought you two patients. What can you do with P2 prolapse? That's our first approach. And the first patient, after everything has been installed, we've cannulated in the groin and lungs have been deflated. You open up the left atrium here, and a placement of the retractor will show you right away where the problem is. There is some problem here at the mitral valve, but every mitral operation starts with valve analysis. So you start off by taking a hook and staying in an area of P1 in this case, where you know this is okay, there is no prolapsing, and you compare it to A1, to A2, A3, and here P3, and you slowly work your way towards the area where you know the problem is, and that's here P2. There are some ruptured chordae, and one more thing that could tell you where the prolapsing is this jet lesion. It shows you that here probably is the problem. So here you make a triangular resection in the prolapsing area with the ruptured chordae and everything. Then you reconstruct the posterior leaflet. And in this case, you don't need to do more because everything pathology is gone. And insert a ring, which is standard in our clinic. And the valve analysis shows a nice smiling valve. So this valve is competent. Let me see whether they want to. Do we need to go to the OR, Ludwig? No.
Just go ahead.
Okay, so I go ahead. So the second patient, I brought you same. I have this run a bit faster for the sake of the surgery. It's P2 prolapse again. And again, a localized area, opening up the left atrium, same procedure. Jet lesion, again, you can see here. So the problem must be somewhere around here, but you always do valve analysis to maybe find something the cardiologist has not seen. P1 is pretty large in this patient, but that's a normal variation. So you see P3 is okay. The problem was P2. So for this patient, we decided to implant Gore-Tex chordae. This is a technique we usually use. We do have loops also, so we can have a couple of Gore-Tex, but we use individual chordae to the referring papillary muscle where the elongation or the rupture of the natural chordae is. Here you see the natural chordae. That's how they should look like. And after implanting the Gore-Tex chordae, either you have marked your area where you want to implant them beforehand, or you can visualize it. So that's what we do. We implant the Gore-Tex at the proper place and do the tying. The placement of the knots is something that can be difficult. So we use a stay suture that is positioned on P1, where we know that the height of the leaflet is okay in this area, and we adjust the others, the new Gore-Tex cordae, to this reference area. So that's how it's tied down. Gore-Tex can be pretty slippery, so you have to make a heap of knots to keep it in place. And there are other methods how you can adjust the height of the posterior leaflet with saline, with other sutures, or there are even rings who give you suggestions, but this is one method. Then you check for any other problems, like deep indentation here, which we have closed for this patient with this suture. Then comes the sizing of this valve. We take the height of the anterior leaflet, or you can also go for the commissures and check where the commissures are. That's the size of the ring you want to use. So next are the ring sutures. You try to avoid hitting other structures like the aortic valve. You implant the ring. And after that, you do your saline probe and check whether there is any other insufficiency, like you can have insufficiencies in the commissures. But for this patient, everything is perfect. We check, of course, after every operation, how the mitral valve is doing and whether there's any insufficiency. We also check for the circumflex artery. Professor Ender from Leipzig has written a paper, actually, how you can detect the circumflex artery. But this is very complicated. So we go for the contractility, the motion of the ventricle. And if you see this kind of a picture after the operation, you know you have a problem with the circumflex artery. Next, we check the aortic valve. You see, not only is the circumflex artery around the mitral valve, but the aortic valve is very close to the mitral. So you can hit it and make this kind of a insufficiency, which we have also. There's no problem that we have not created. And this is the reoperation for the aortic valve. So this is our setup for minimal invasive mitral. You have a perfect picture with 3D, as you can see on the monitor. And this is my foremost slide. And what is the problem is, you see, we have a new operative setup, we have new instruments, and we have a new workflow. So we have to check whether our new strategy is working. How are the patients doing? How are our results? This is my last slide, Ludwig. And so do we have comparable results? That is what we were interested in checking with our quality management paper. So we checked our first 842 patients. We have done over 2,700 patients up to now. And with the first patients, where all the complications are at the beginning, we saw that we have a very excellent reconstruction rate. This is, of course, very biased. These are highly selected patients, of course. There are lots of exclusion criteria, especially at the beginning. The further we go, the more courageous we are, and we add calcifications, we add aortic insufficiencies, things we wouldn't have done at the beginning. So this terrific number is probably because the patients are highly selected. But we're very glad about that the mortality rate has not been worse with the minimal invasive, and everything looked fine. So that is how we implemented the minimal invasive strategy in Bad Neustadt. Thank you.
Thank you very much, Fitzum. Beautiful lecture. As we share the same teachers, we have a very similar approach. And also thank you very much for this, not just instructive, but also very honest presentation. You mentioned there was no problem we haven't created.
Yes. No.
And I can just underline that it's true, also from my side. Maybe, Dimitri, you have taken over the endeavor to implement minimal mitral valve surgery in St. Luke's again. Have you any comment on that?
Yes. First of all, I would like to felicitate Dr. Fitzum for the excellent presentation and for your presence here in our city. And I would only like to ask you something about your first and second case that you presented. I saw that in your first case of P2 rupture, You preferred, instead of doing neocordage, putting new cordals, to make the triangular resection, although there was not a big excess tissue. In the second, you directly went for new cordals. Which are your criteria for choosing when I'm going to do a resection and when I'm going to do the new cordals?
Yes. Between these two recordings of the patients lies many, many years. We don't do so much resections anymore. The resection, I really have to go back many years to select patients.
That was also the question, because we are mostly using in our practice of endoscopic treatment of mitral valve, we mostly use loops.
Yes, that's the way to go now, especially since Patrick Perrier has taught us how to respect the valve and not to resect too much. But if you do resect, you just make a triangular resection. That was what I want to show. I just want to show you can do a lot of things with this valve. You can implant chordae, resect, or, different techniques. The snail technique is new, and there are many, many ways to roam. And you have to choose the one that's best suited for you. I think that's the way to go.
Thank you. I think we have two discussions online. Maybe Dr. Panos, can you comment or ask questions?
Good morning. Thank you for this meeting. Dr. Lakew, thank you for this presentation and the way how to do it at the first times. And my team, we have started also in 2007, so quite a long time ago. And we did it the same way. I went back to the Dr. Van Herman and stay there for some times, and then come back and create a team. And this is the only way to do it correctly, as you have mentioned. And then I have to also to agree with Dr. Sardari, who mentioned that centralization and high volume for this kind of very specific surgery is a key to the success. Thank you for this presentation again.
Thank you.
Thank you for this comment, Dr. Pattakos. Dr. Panos, maybe Dr. Pattakos also wants to discuss this presentation?
Yes, thank you very much, and thank you for this kind invitation. I had the privilege to visit Bad Neustadt and seeing Dr. Fitzum along with Dr. Perrier, that we had a very close cooperation at that time. And I really do appreciate the hard way to start, especially minimally invasive, because it's a very tricky situation. You can see it appealing at the first, but if you don't establish all these guidelines and all these strong cooperations, the learning curve at the beginning has a lot of surprises. And I've seen all those surprises internationally. Seen surgeons that have tried it in London, here and there. And with a few mishaps at the beginning, they had to stop the program. So I'm very skeptical and very, very serious about how to establish it very nicely. It's a privilege for us to have also Nia Sardari visiting us in our center, as we had Dr. Perrier also. And I think their input is very significant, because quality is a big issue at this point. So really congratulations for this pioneering symposium, the opportunity to participate and see and communicate our experiences. And really, it's very nice. Looking forward to see what Dr. Kofidis is doing in the OR. Thank you very much.
Thank you so much.
Thank you.
If there are no other questions, thank you, Fitzum. Fitzum, thank you so much. I've just been informed that we have to go live to the OR after 11. So